Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Andrew Spector. He's a neurologist. Today's KevinMD article is The Unexpected Truth About Restless Leg Syndrome Treatments. Andrew, welcome back to the show.
Thank you very much, Kevin. Glad to be here.
All right. So, your most recent KevinMD article is about restless leg syndrome. So, before talking about the treatments for it, just give us some background in terms of what restless leg syndrome is.
So restless leg syndrome is an unpleasant sensation that affects mostly the legs, and people often describe it as an urge to move. And it tends to get worse at night, worse when you're resting and holding still, and better if you're up and moving. So it's a pretty simple, straightforward, subjective criteria for diagnosis.
And what typically causes that?
So we think the most common cause is a low iron state in the brain. So a lot of people are brain iron deficient, and that triggers a cascade of changes in the receptors in several different pathways in the brain, leading to the symptoms that we talk about.
Okay. So your article is about the unexpected truth about restless leg syndrome treatments. Tell us about that article for those who didn't get a chance to read it.
Yeah, so for the last 20 or more years, the first line therapy for restless leg syndrome has been dopamine agonists, specifically ropinirole, pramipexole, and rotigotine. And those three drugs have been widely used by many, many patients with restless leg syndrome, and unfortunately, often to their detriment. Those drugs are highly effective when you start them. And so you get this profound sense of relief that finally something is treating this restless legs. And then as treatment goes on over the course of months to years, more and more people develop this complication that we call augmentation. And augmentation is when the symptoms of restless legs get worse. Maybe it's spreading to other parts of the body. Maybe it's starting earlier in the day. And this is a result of the long-term use of those three drugs. And so when I talk about the surprising truth, the issue is the drugs that we're using are actually probably making the problem worse for many people.
So just so I understand, someone comes in, gets diagnosed with restless legs, and traditionally they'd be put on one of these dopamine agonists, and it would work for a couple years, but then the symptoms eventually from the restless legs would get significantly worse. Is that
Right.
what you're
And
saying?
it's a seductive drug because if you go back to the doctor and say, you know what, this drug's been working great for me for the last year, but it's starting to not work as well, and the doctor's reaction is to say, all right, well, let's bump your dose up a little
Hmm.
bit. It's going to work again, and you're going to go out and you're going to feel great again until you don't.
Hmm.
And it's a vicious cycle. And then you start accumulating more and more side effects of the drugs. So maybe you start to develop orthostatic hypotension. You get lightheaded when you stand up. Maybe you start to develop daytime sleepiness. Or one of the most dreaded complications of these drugs are what we call impulse control disorders. So you become a compulsive gambler, a compulsive shopper, compulsive eater, compulsive pornography user. These are well-known complications of the drugs as the dose goes up. So every time you go back and say, my legs are worse, your dose goes up, you're increasing the risk that your restless legs will get worse, and you're increasing your risk of one of these terrible complications.
And when patients come to you in that scenario you just described, where they're in that vicious cycle, what are your options as a neurologist when you see them?
So the first step is, first of all, convincing patients that these are the harmful drugs, right? They've been on them and they've been working. So their perception is every time I get a dose increase, it works. So you have to kind of walk that back a little bit and say, yeah, it may be helping, but it's actually making it worse. And then we look to the iron. When I started out by saying this is a disease of iron deficiency, it's not necessarily a blood iron deficiency. If you check the blood levels of iron for these people, often they're normal based on what the lab defines as normal. But in our world treating restless leg syndrome, we don't want normal, we want high iron. We
Hmm.
want to push that level up because a lot of times people have trouble moving the iron from the blood into the brain across that blood-brain barrier. And people who have trouble moving iron from the blood into the brain are going to often develop restless legs as a result. And so we do a lot of iron infusions.
Hmm.
Push the iron level up, give it right in the IV, and make that high level of iron. And that creates a better environment to then try to get off these dopamine agonist drugs, the pramipexole, ropinirole, rotigotine, and move to the safer options.
And in terms of weaning patients off that drug in the setting of IV infusion of iron, what kind of time frame are we looking at? How successful are you in doing that?
There are a lot of different schools of thought on this. And so, speaking from my practice, I tend to be a little slower with the wean. I know there are people who really go aggressively to wean off these drugs. I tend to be patient because coming off a dopamine agonist, it can be miserable. And you go through a terrible withdrawal sometimes. So I try to set the stage for success. I get the iron in, and that could take 2 months for the iron to have full effect. It doesn't work immediately. And then I try to find a drug to help mitigate those symptoms. That might be a gabapentin or a pregabalin medication, or it could be an opioid medication like methadone or buprenorphine, which are highly effective. And I try to cushion then the symptoms of restless legs when I very gradually take the dopamine agonist away. I'll be more aggressive if they've got compulsive gambling or compulsive shopping. I don't really want to wait around to get them off the drug if that's going on. But if it's just an issue with augmentation and they're suffering from bad restless legs, then I will more gradually take them off to avoid as much withdrawal as I can.
And to be clear, how often is it that patients eventually would have some of these complications to dopamine agonists? Are we talking about the majority of patients? Are we talking about small subsets? So, what kind of numbers are we looking at?
So the majority, and there are some out there who will say that everybody will eventually develop it if given enough time. I don't know if it's truly everybody, but it could be 70%
Hmm.
of patients will eventually get have a problem with augmentation if left on the drugs long enough. So it's a high enough number that we really need to be thinking twice about using these drugs.
So, how about in the primary care setting then? If I see a patient that I suspect has restless legs, what are the options that are available to me?
So number one, iron. That's and number two, removing triggers. Antihistamines, anti-nausea drugs, anything with anti-dopamine properties, antidepressants, so all the serotonin drugs, they can all make restless legs worse. So can caffeine, alcohol, nicotine, and sugar. So you can counsel about removing the triggers. You can certainly start gabapentin or pregabalin, and you can get iron treatment going. Those are all great things at the primary care level. I wouldn't advise using dopamine agonists at this point at the primary care level. I will use them in select patients, knowing I've got to keep the doses very low and try to use it as an as needed medication, maybe not a daily medication, but I think it's safer not to be using dopamine agonists in primary care.
And then when you say iron, is oral iron, would that be good enough? And how would I, you said that there's no correlation between the blood iron levels. So tell me
Right.
how I would start oral iron in patients like
Yeah,
this.
absolutely. So ironically, iron orally is better if your iron is lowest. So we think sometimes, oh, it's really low, better do an infusion. In fact, it's the opposite logic with iron. And that's because the lower the iron level, the better your gut's going to absorb the oral iron. So the people who have not just brain iron deficiency, but also blood iron deficiency with low ferritin levels, a ferritin of 7, 10, they'll often do really well with oral iron because their bodies are so starved for iron, they'll absorb it all.
Hmm.
Once you get to ferritin levels like 75 or even 100, the body's just not going to absorb a lot more iron. Those are the folks where I'd say we'd still go for an iron infusion. And the thresholds we use, the guidelines suggest that if your ferritin, sorry, if your ferritin is less than 100 or your transferrin saturation is less than 20%, should go ahead with an iron infusion. And the reason we use both is because ferritin is an acute phase reactant. That'll go up just because you have inflammation.
Hmm.
So we can't always rely on the ferritin, and that's why we use the percent saturation also, because that's not an inflammatory marker. But it's also important to note that iron levels need to be tested in a fasting state in the morning because those levels can fluctuate throughout the day. So testing the iron in the morning, not when you've been taking an iron pill. You can't take an iron pill, then check the
Yeah.
blood iron. That's the best way to do it.
And what can a patient expect after getting an iron infusion in terms of the relief of their symptoms?
So iron infusions are not as scary as they once were. When I was in med school, we were told not to do them because of the risk of anaphylaxis. Those risks are not present in nearly the degree that they used to be. So the immediate effect is that they're probably going to tolerate it very well.
Hmm.
Maybe a headache afterwards, maybe some muscle aches, but the restless legs doesn't tend to improve for about 6 to 8 weeks. So I tell people you do have to be patient. It's not an immediate process.
And the iron infusions, do they have to be done eventually on a continuous basis? Are the patient going to be on iron infusions long term to maintain relief of their restless leg syndrome?
And that's a great question. I get that question a lot. And the answer is no. A lot of times when we tank a patient's iron up to a nice high level, they're good to go. We've really just changed their baseline level of iron, and they can stay there for quite a while. Maybe a couple years down the road, it'll be time to do another one. But there's no set rule that says you have to do it every year, every 6 months. We're just monitoring levels. And if the iron does drop again, we're open to doing another infusion, but there's no set frequency or no guarantee. I'd say the population most likely to need a repeat infusion are maybe menstruating females who are losing blood each month, may need an iron infusion more often. But postmenopausal women or men tend to hold on to their iron pretty well.
So let's talk about augmentation again. So again, in the primary care setting, if we have patients who are on these dopamine agonists for a period of time for their restless legs, what kind of things are patients saying that would make me think that this is in fact augmentation? What are some typical phrases or sentences or symptoms that they would come to me with?
Yeah, so I'd say there are three common ones. First, they'll say it's just not working as well as it used
Okay.
to. Number two, they need it earlier. They're not making it to their nighttime dose. So normally their restless legs will kick in around 8 p.m., for example. Now it's starting at 7 or starting at 6. So earlier. And then the other one is spreading. So it was just in the legs. Now they're starting to feel a little bit in the arms too, or something like that. So I'd say those are the big three red flags that they're starting to develop augmentation.
Now, what about non-pharmacological treatments? You mentioned perineal nerve stimulators. So any device approaches to restless legs? What do we have to look forward to?
Yeah, so just earlier this year, we have our first really effective device treatment, which is really exciting because, I mentioned earlier that some of the advanced drug therapies include things like methadone and buprenorphine. And while they work, if we don't have to use opioids, we'd
Okay.
rather. And these devices, it's a band. You put it around the leg just below the knee, and it stimulates the peroneal nerve. It actually stimulates the afferent fibers. So it creates a spinal reflex arc, and that creates tonic motor activation. It's called a tonic motor activation device that simulates what voluntary movement of the leg would feel like. I've tried these on. It almost feels like a really mild vibration in the leg. It's not the same as a TENS unit. People often ask because it's not creating a muscle contraction that you can feel. Your leg is not visibly moving. It's just like the sensation of a vibration in the leg. And the patients I've tried it on have been pleased with it so far. It's still early because it just came out this year. But so far, my anecdotal evidence from my own patients is quite good and
We're
very
talking
well tolerated, I should add. There are no major side effects from this thing.
we're talking to Andrew Spector. He's a neurologist. Today's KevinMD article is The Unexpected Truth About Restless Leg Syndrome Treatments. Andrew, as always, will end with some take-home messages to the KevinMD audience.
Yeah, my biggest take-home message, especially, is take restless legs seriously because it makes patients absolutely miserable. It's one of the things that absolutely destroys quality of life. That's take-home message number one. Number two, it's very treatable. These folks who are coming to me with severe augmentation, they're all better by the time we get them off the drug. Augmentation is reversible. There are good treatments, and never give up because if you get to a restless leg specialist, we can help almost everyone, if not everyone, to feel better.
Andrew, thank you so much for sharing your perspective and insight. And thanks again for coming back on the show.
Thank you very much, David.